Our next paper is coming to us from London, the financial impact of introducing a robot to a pediatric surgery and urology program in the British National Health Service. Dr. Simon Clark.
Thank you very much. And thank you for allowing me to present our first year's experience with the introduction of a robot in the British National Health Service. Oh, not that one. This one? No. I have nothing to disclose. In 2006, at the Chelsea Children's Hospital, we have a charity, and we began fundraising under the vision of my colleague, Muntha Haddad, to purchase the UK's first robot exclusively for children. And 7 years later, after a lot of bring and buy sales, car boot sales, marathon running, we eventually crossed the finishing line and raised the £1.2 million or $1.7 million required to purchase the device. And we had, sorry, I'm not doing this very well. We had the help of, if you could play the video, please, to launch our program in the beginning of 2014. We had the help of a couple of celebrity neighbors. One of whom took to the machine slightly better than the other, who seemed to struggle, and we suggested that he stuck to his day job as heir to the British throne. Robotics and ped surgery in Britain. There's 31 hospitals at the moment that have invested in a Da Vinci surgical robot, but there are only 2 children's hospitals that offer robotic surgery. The first one was in Leeds, where they purchased it in conjunction with the adult service, and we were the first to offer it exclusively for children. The British National Health Service, for those of you who don't know it, is something that we are immensely proud of in the UK. And this is a service which is free at the point of entry to all, and has been since 1948. But like any government-funded health service, the last few years have been tight, and unlike this tree in America, money doesn't grow on trees in England. So we decided to carry out not only a clinical outcome study for the first 12 months, but a financial outcome analysis. One of the key drivers for our business case, in the initial financial business case for purchasing the robot, or the maintenance contract of it, was the assumption of something called the halo effect. And this is a concept that was first introduced by psychologists about nearly a century ago, where something is seen in a very positive light. And as a result of this, other positive things are attracted towards it. So the introduction of a robotic program we thought was innovative, and we convinced the management that this would increase, in a clinical context, the amount of patients that came through the door, not only just in pediatric surgery and urology, but also for the whole hospital. So it seemed to work. In terms of our analysis then for the first 12 months, we looked at training costs, maintenance costs, cost per case, including the OR time, as well as the actual cost recouped per case that the government gives us back. We looked at analgesic requirements, and we did a prospective data collection. But we looked at particularly the key performance indicators that the government measures us on, and that is length of stay and readmission within 28 days. So the halo effect, we measured this by looking at the number of referrals compared to the previous 12 months of introducing and announcing the robot's arrival, and the number of surgical procedures compared to the previous 12 months. So far, in a very carefully selected group of patients for our first 12 months, we've carried out 28 procedures with the following, as you can see. So far, to date, all our procedures are longer. by as much as twice as long as their laparoscopic counterparts. The length of stay is unchanged. The analgesic requirement is unchanged. And the cost is up to as much as 200% more expensive, particularly in the case of laparoscopic appendicectomy. I'm told by my urology colleagues that the ureteric reimplantation went home a day earlier. That's the only, so far, positive outcome we have compared to our laparoscopic benchmarks. How did we calculate the cost? Not only, don't forget, we had to take out the initial purchase because that was a gift by our charity. We had to buy new sterilization equipment for the camera. The amount of consumables, not only for the instruments, which have a 10 to 20 limited lifespan, but also for the drapes, all had to be specialized. Training costs, we have to travel to Strasbourg in France. There is no robotic ERCAD center in the UK. And we also flew in mentors from, validated mentors from Da Vinci for the first few cases. And the average cost per case took also into account the extended procedural time, which I think is really important when looking at robotic costs, because there are many studies that haven't done that. And we estimated this in pounds, and about nearly £10,000 per case for the first year, which is about $14,000. And the overall income that we received for the first 28 cases on average, some more, some less, was about £7,000 or $10,000. And the tariff that we got back from the government is the same as laparoscopy, so we can't charge any more for it being robotic. And in some cases, the same as open. What about the halo effect that we were really gunning for with our management, who hold the purse strings? Well, the overall procedural activity for the first 12 months after the introduction was unchanged. So we weren't doing any more operations. But there was a 20% increase in referrals to the outpatient department compared to the previous year. Now, this might be spurious, and we'll have to continue to prospectively look at this as to whether or not this is real. But overall, when balancing the books, the final deficit for the first 12 months has come in the region of about $170,000 for those 28 cases. And the accountants have predicted the future losses, if we carry on at this same rate over the next 5 years, together with depreciation of the machine, by as much as $300,000 or $450,000. So my first conclusion is that the introduction has already resulted in a significant financial impact to a very strained national health service. Its evidence for use in pediatric surgery, as you heard this morning, and from Holger yesterday, it's limited, but it's growing. There's about 250 articles in the literature. But we need to collaborate more, particularly from the pediatric surgery fraternity, in order to establish whether or not this is real and whether or not we should continue for services such as ours, which is a government health service, to further invest in this program for children. So we'll call upon IPEG and possibly industry to help us in the formation of an international funded prospective robotic registry to be established for our specialty. Thank you very much.
This paper is open for discussion. Mr. Clark, I thought that was a fantastic presentation and study that you did. Not being familiar with the NHS, if you could just bear with some of my questions, as mundane as they may seem. Number one, I have tried to perform some cost analysis in my hospital, and most often I get hospital charge data, but I'm not able to get the actual cost data. Mm-hmm. So I'm interested to know if you're able to get the actual cost data. The second thing is, in terms of the halo effect, part of this is also related to marketing, and is there a regionalization in terms of referrals within the NHS system
Yeah.
And could you cross different regions to get referrals from them?
Well, we do, and we have, and that's what I think we're noticing, not only for our department, but also for pediatrics in general. And I mean, having the Prince of Wales come to open it and play on it, certainly, I'm sure, made quite a difference, but he can't do that every year. So in terms of the cost, I mean, you're right. I think sometimes even the accountants don't really know how to cost things properly. So the figure that I've got there is very much an estimate. But it does take into account nursing time, operative time, anaesthetist time. There's many publications out there which look at cost, and they don't look at the length of time in the operating theatre and include that. And I think for someone like us who are just beginning, it's really important to put that message to anybody else who's also just trying to think about beginning.
Yeah. Thank you. Ashwin?
The thing I wanted to ask you was that, okay, you're having problems in the first year. How are the leads people doing? Did you inquire from them? Are they, after, they have it for like 4 or 5 years now.
Yeah.
What do they think?
Well, I think we have to follow, and business cases are already being put forward to now join up with the adult team. So we can no longer use this on our own. So the colorectal, bariatric, gynecological services will all join in. And that's really how it's been possible in the other center. Yeah.
Christine White, Albany, New York. We've introduced robotics into pediatrics, and I think probably for the first time I realized that I'm lucky that our center is within a general adult center, because we've been able to graft our program onto the adult thing, you know, and it's been good. So what are you going to do now? I mean, are you going to press on? Are you going to sell it, second-hand robot?
We've managed to sell it for another year. But I think the formation of a registry and involving people like yourselves in New York and John Meehan and together throughout, and IPEG's the perfect venture place for this, that we should start to collect our data together.